Hello, I'm Dr. Marla Shapiro. I'm a past president of the North American Menopause Society, and today I'm joined by Dr. Lisa Larkin. Lisa, for our healthcare practitioners who don't know you, please tell us who you are.
So I'm a women's health internist in Cincinnati, Ohio, and I'm founder of Ms. Medicine. I'm also on the board of trustees of NAMS currently.
So let's start with where we are right now. Medicine and menopause medicine for many of us, whether we wanted to or not, has very much transitioned because of where we are in the world pandemic. For many of us, we've begun to do virtual online medicine. Many of our patients don't want to come in or they feel that it can be done virtually. Let's talk about the benefits first of that, and then inevitably some of the worrisome pitfalls that we may not even know that we're looking at.
So sure, so I think this is in many ways a really exciting time in the women's health space. So there's been two things that have come together. One, the explosion of interest in women's health and the explosion of the femtech industry, as well as COVID. And both of those two things together really drove the acceleration of telemedicine and virtual visits, which in many ways has really positively impacted women's health. We now have more awareness of menopause and women's health issues and the unmet medical need of women's health, but we also have the opportunity to extend our reach and to really penetrate underserved markets and underserved communities where access to expertise in menopause has been lacking.
So let's first talk about us as individuals, and then the broader notion of what has evolved in, as you call, the femtech space that we don't do, and where we might have to think about buyer beware.
Correct. So I think one of the biggest things is that not all telemedicine is the same, right? So I like to think about it in categories, right? So virtual visits for a patient who has an established relationship with a provider is one very outstanding way, I believe, of expanding access to care and virtual visits in the women's health space for many conditions like menopause, when you have an established relationship, can be outstanding. The problem is there's two other categories of virtual visits where, and telemedicine, where it's a little unclear what the benefit is or if we're able to deliver quality and cost. And what I mean by that is individual platforms where patients don't have an existing relationship with a provider but have individual consults with a provider for a particular menopause issue. The problem with that is that there's no coordination between the patient's primary care provider, there's no really longitudinal follow-up, there's no ability to refer, and I think it's really unclear whether or not quality is actually the same, and whether or not there's any concern about delay in diagnosis or misdiagnosis. The third category is really, and it's still in the telehealth space, really what's e-commerce pharmacies, right, where patients can access an online form which is reviewed by a bot or sometimes a physician and get online prescriptions mailed to them with really no face-to-face interaction, not even really a phone call, no phone call. And so that's not really the same telemedicine, right? And so consumers, we talk about it in like they're all the same, and really they're not the same.
So I know within my own practice, and I think you're right, that when you have an established relationship and you know when was your last mammogram, when was your last PAP, what other medications are you on,
Correct.
what is your bone health, is a different situation. But even in those situations, the fact that we're seeing them remotely and a patient may not clarify every symptom that you might otherwise get in an office always sits with a little bit of trepidation in my
Yes.
own mind.
Yes.
How do we blend this, and when what guidelines would you suggest where we say this can't be just virtual?
Right, and that's one of the things that's really happened, I think, which is the cart's gotten ahead of the horse, right? Which is with both the femtech explosion and COVID, which drove the adoption of this so quickly, we really don't have, in everything else we look for data, right, to guide us, to say this is an appropriate thing for telemedicine, and in these circumstances this works very well, and in these circumstances really you need a physical exam, you need an in-person visit, and how actually the other pieces to incorporate those things, right? So I think what's happened now is we're kind of starting to say, oh my gosh, maybe we've gotten ahead of ourselves and we don't have those exact guidelines, because I, like you, have seen and in practice have used where I think telemedicine is excellent and can be very helpful. But again, like you, I'm very concerned that I have to have an established database on a patient and complete health records to be able to provide complete care. Where I've seen misses is with incomplete care, and where I think there really are concerns about delay in diagnosis or misdiagnosis, or even in a situation, I recently had a patient come in who could not access the provider again, who had given her, frankly, misinformation, and I, as the physician, couldn't get records from that company as well about what actually was said and what was done. And so I think we need data. We need to take a step back and look at this and really make sure that we are providing high quality evidence-based care and we're not doing more harm than good.
And I think, we don't ever really sort of want to talk about the medical legal ramifications, but
Sure.
But you can't not think about the medical legal ramifications. But even more important than that to me is the concept of every once in a while we do have to do the laying on of hands, so to speak.
Yes, and I 100% agree with you. And again, there's been a lot of talk that, talking about the pros and cons of hormone therapy or deciding about, menopause is very ideally suited to telemedicine. But again, like you, I think it's not perfectly suited, and that there are really times when we really need to do a physical exam, right? Not all hot flashes are related to menopause, not all vaginal dryness is related to menopause, and there are very important things that we do in a physical exam that, again, even just in a virtual sense, you can miss things, of course, right?
It is clear, given COVID and the impact that it's had, that virtual medicine is not going to go away. I think we've seen a paradigm shift now that is with us, I don't want to say forever, but for the foreseeable future, where a lot of patients really do want to have that virtual component. Is it a component only? And, where do you think we're going?
Well, so you're exactly right. And, you and I have children who are in the millennial generation. And, I've watched my son, who is a millennial and very tech savvy, and he loves the fact that he can basically have a primary care doctor that he thinks is virtual. It's all email and text, and that's the greatest thing going. Now, he's a healthy 26-year-old, right? So and it's here to stay, right? That generation, they love that tech component, right? The question really is that appropriate for everyone? And you and I both know that it's not, right? Particularly as we age, health conditions become more complex, and I really worry that we don't have guidelines and that we really will have misdiagnosis and delay in diagnosis. And for me, I think we have to get a better lexicon to distinguish between the different types of telemedicine and virtual care. Because again, like you, I'm 100% in agreement that it's here to stay, and I think there's really positives that have come out of this push in technology, again, to extend our reach to underserved communities and to really expand care in areas where we've missed. But again, we have to balance that with really the concerns about delay in diagnosis or misdiagnosis, and I don't know how to do that yet. I think we need to roll it back.
I think we're going to end this with me saying, same time next year, you and I will sit down
and we'll see where it is.
We'll be able to look at one more year of information and data and see if we can build a foundation to what clearly is something that is not going away.
Right. Thank you.
Thank you.